the way I see guys coming into the office and they're distressed with the kind of dysmorphia associated with the curvature, not from corporal mismatch, but really Peyronie's disease, is when the curvature becomes so bad that they are having difficulty with penetrative intercourse. They're not able to have penetrative intercourse, or either intercourse is painful for them or their partner. That's where it becomes kind of difficult and really impedes on their quality of life. Now, the thing to keep in mind is, in the initial kind of first few months, anywhere from 3 to 6 months, in the acute phase in Peyronie's disease, most guys have painful. In the acute phase, that's when the remodeling is occurring, that's when the collagen fiber is getting laid down, and that's when the curvature is forming. So in the acute phase, most of those guys are having painful, so it also can impact their desire to want to engage in activity. Once you get into the chronic phase, once the plaque is essentially laid down, stabilized, and formed, that's when they no longer experience that pain with.
Is there a linear process here that each man who experiences Peyronie's disease goes through? Okay, and if that would be the case, are there early warning signs and symptoms that a man could pay attention to so as to try to get ahead of a more progressive or aggressive curvature forming?
Okay, so there's unfortunately no linear pathway for Peyronie's disease. So some guys don't have pain with. Some guys get pain with early on in the acute phase. And typically I tell patients that whatever your curvature is as it presents, the first time you notice it, that's typically the way the curvature is going to be. It's not going to progress and gradually go from 30 degrees to 90 degrees and so forth. It's whatever the curvature is at the moment it presents, that's typically what you're going to expect kind of lifelong if you were to do nothing. I like a combination of a few things to help with anti-fibrosis or anti-fibrotic properties. I'm a huge fan of L-citrulline. It's a nitric oxide precursor, gets metabolized by the kidney, turns into L-arginine and then nitric oxide. So L-citrulline, great, recommended all the time. Something else that I think is really important is nattokinase, Nattokinase. Typically, I would say about 10,000 units a day. And nattokinase is a natural occurring enzyme which can potentially help to break down plaques in the coronary arteries. And so you can extrapolate the data, and anecdotally, I've had some success in patients just taking nattokinase for treatment of their Peyronie's disease. Now, the other things I want to quickly talk about is the benefits of a traction device. So a traction device is a wearable external device. It's kind of a set that you put on the and it puts traction or tension on the to try and soften up that plaque that's creating that point of tension and curvature, to soften up the plaque to try and straighten out the
Mm-hmm.
And then lastly, something I think that's really important is Xiaflex. So Xiaflex is the only FDA approved medication for the treatment of Peyronie's disease. I'm the number one volume injector here at Cedars-Sinai for Xiaflex for Peyronie's disease. Thankfully, I have a lot of experience doing this, and the outcomes, although mixed, I would say most of my patients do really well. It's a series of 8 injections spread out over weeks, given directly into the plaque. It's with a small kind of insulin syringe, small little needle. And we directly inject this collagenase medication called Xiaflex into the plaque to try and gradually break down the plaque. Now, the last option really for these guys is surgery if all else fails, or they're not a candidate for Xiaflex or traction. So the surgeries for Peyronie's disease are what's called a plication, meaning let's say someone has a leftward curvature. This becomes the long side, this becomes the short. This becomes the long side, this is the short side. So by shortening the long side with stitches, we can get the become more straight. The problem with the plication is that you lose length.
Right.
So not a lot of guys are interested in the plication. And then the other option is what's called a plaque excision and graft placement, where I can cut the plaque out that's leading to the curvature and put a patch of tissue, typically what's called cadaveric pericardium, meaning the cadaver's lining of the heart, the pericardium, It's decellularized, and then I use that as a graft to sew onto the area that I excise the plaque from. So there are a lot of treatment options. Some are less invasive, some are more invasive, some are in between. But there usually is something to do for every patient.